Okay. This is my only disclosure. This has been said before, but I just want to attest to the fact that while not all people who can be pregnant or give birth identify as being a woman, I use the term women instead of people or persons intentionally. And it's really to highlight the vulnerability of people whose society typically identifies as being female. I don't mean to exclude or silence anyone, but to draw attention to the ways pregnant or postpartum people are discriminated against, largely because of their female gender assignment at birth. And this is something that I have borrowed from the Illinois Department of Public Health. They said this even more eloquently, I believe. Thank you. So I've been asked to talk about thinking out of the box. How do we think about eliminating racial disparities in maternal health, maternal mortality, and morbidity? And my ideas are the following. First, I want to just say, I know we love to focus on single clinical interventions, but I think at this point of the day, we understand that no single clinical intervention has substantially reduced maternal health disparities. This has been said over and over, and I want to restate it, that health during pregnancy and postpartum is obviously not an isolated event. Health is much more. It's about our social and environment, and it's much more than just clinical. And we need real paradigm shifts in how we deliver care in a respectful manner that establishes trust and engagement primarily for Black and Brown women. And health begins and ends in the community in which people live. We've heard something about this today, about chronic diseases, and that can increase the risk of pregnancy complications. A lot has been spoken about obesity today, and I've seen several comments about addressing obesity. Joya talked about marriage and how whether being married or not can really impact racial disparities. I want to say the same about obesity. If I were queen of the world, well, my first act would probably be getting the COVID vaccine for every pregnant and postpartum person who wants it, and educating them on why they should want it. But if my second act was to make every Black woman skinny tomorrow, I contend to you that while we might see some small decrease in chronic health conditions, racial disparities in maternal mortality would still exist because they exist in such a much broader category than whether a woman is overweight or not. And I want to ask you that every time you say to a pregnant woman who's overweight, you have to lose weight, is you think about who the woman is, the context of her life, what access to good food she has, what access to exercise she has, because these conditions don't happen in isolation, and they're so commingled with life experiences, social determinants of health. So we know that the underlying causes of pregnancy-related deaths vary by race and ethnicity in Illinois. That's where I work, primarily, in fact, in Chicago. And that our overall leading cause of death, when you looked at all death in the state of Illinois, were due to mental and behavioral issues. Black women were almost 3 times as likely as white women to die in Illinois from a pregnancy-related cause, and had a twice the rate of severe maternal morbidity. But when you looked at the data, what we found is Black women are more likely to die from a pregnancy-related medical condition, chronic diseases, hemorrhage, hypertension, and white women from mental health conditions, including suicides and drug overdoses. So it's really important that if in Illinois we only looked at the leading cause of maternal mortality and looked at interventions to change that, we could in fact be increasing our racial disparity. And when we looked in Illinois at the social determinants of health in these pregnancy-related deaths, what we found is of the women who died from a pregnancy-related cause, a third experienced traumatic stress, and that in 62/3 of the pregnancy-related mental health conditions, there were traumatic stressors, and that 3/4 of these women also experienced financial stress, and we're beginning to understand a lot of housing insecurity now too, which has only been made worse by COVID. So the high prevalence of these stressors really highlights the importance of evaluating a woman's trauma history and improving all the services that surround her, not just the clinical care she gets when she comes in for her prenatal visit. So how can research address racial inequity? Well, we need to think creatively and think about what the new ideas are. So I want to talk about a new study that I'm involved in that's been funded by PCORI. And the basis of this research in Chicago is that the research showed higher rates of exposure to structural racism is associated with adverse maternal and birth outcomes among Black women, and that Black women themselves report 54 to 78% report experiencing racial discrimination. I can't even believe it, the 54%. I assume it's much, much higher than that. And in the US, our structural racism has historically been used to advantage white people over Black people. And that includes the implementation of multiple discriminatory practices. And Joy eloquently talked about a lot of this, slavery, Jim Crow, redlining, mass incarceration, lack of intergenerational wealth. And this all limits the access to quality housing and education and good healthcare, and results in marginalization in healthcare. So this, for me, and for a lot of people engaged in this work, this structural racism explains why Black people lack trust in the healthcare system. How could they not? Right? And it leads to low patient engagement and attendance and care. And we historically say women were not compliant with their prenatal care. Well, I always say, well, why would they be? They come, they have long waits, they're not treated well. When they do come, we talk about how overweight they are. We talk about why did you miss your last visit? It becomes blaming, and in fact, when we talk to the women on the south side of Chicago, where we have a historically lack of adequate health care for Black and Brown people, they said they want to be able to come somewhere where they trusted the providers. Then they would be engaged. If they felt welcome, they felt respected, and they could establish a sense of trust. So we have just been co-PI on this study. It's a PCORI-funded study to address racial inequities. And it's a real culture change and paradigm shift. It's meeting women where they've told us they want to be met. They have helped give input into the design of this. And they want to feel trusting, and they want to engage. And so we're working with a group called the Melanated Group Midwifery Care, MGMC, and they fill this gap because they have been traditionally responsive to Black women. And it's a culturally adapted and patient-centered program of care. And this is just a little bit about the Melanated Midwives. They're on the website. I'm working with the head midwife, Dr. Carrie Stewart, and other colleagues. And this is what we're doing. We have 4 strategies. One is racial concordance between the providers and the Black patients. This is what the women in the south side of Chicago have asked for. They feel that this will help increase their engagement in the healthcare system and earn trust and improve satisfaction. And it has been shown to reduce racial disparity. We're taking the racial concordance of Black midwives, working with Black care coordinators, Black postpartum doulas, in a group healthcare model. And these are sort of the 4 components of our strategy that we will be using. And it was interesting. I'm just going to go back for a minute, because one of the ways that we were able to get this grant is that the grant got reviewed at PCORI, and it did well scientifically. And then PCORI got on the phone with us and talked about their concerns, like, there's no single strategy you're doing here. How do you know which one of these 4 things makes a difference? And what we were able to do in a conversation with the program officers, several were on the phone with us, is say, because it isn't about any one thing anymore, it's multifactorial. And the whole here is greater than the sum of the parts. And I think we were funded because we were able to have this conversation. And I would suggest that it's a new way for funders to think about engaging with researchers. So a few thoughts that really build on what Joya has talked about. Sex may be a biological variable, but race is not. And we have to stop thinking about being Black as what the problem is. Being Black and being overweight. If we can't move beyond those 2 concepts, we're not going to make progress. We really have to start talking about racism. And I know when we see a woman clinically, our main concern is often her blood pressure is going up. I don't want her to become severely hypertensive and preeclamptic. And we singly focus on just trying to fix that isolated morbidity, but it didn't happen in isolation. And I know we can't fix everything as clinicians and researchers, but we need to expand our vision about how we think about it. So we really need to focus on changing policies and systems and environments as opposed to changing the people. And I think we also need to think about new kinds of ways that we do research. Implementation science couldn't be more important now. It's not just about the primary outcome, but was it feasible? Was it acceptable? Another example is Illinois became the first state to extend continuous eligibility for full Medicaid benefits through 12 months postpartum. That's wonderful. I mean, we looked at all our maternal deaths and we saw a lot of women needed continuing health care. But we don't actually know what the impact is going to be of that change. And it's really hard to get funding for research to evaluate that impact. So we really need to think creatively about funding those kinds of research endeavors as well. I don't want to put this all in NIH. They need to partner with other agencies. I think NIH, PCORI, and HRSA and FDA should work more together. I know they're trying. Again, partnering with communities, listening to what the community wants and letting them lead the way in terms of what's important to them, bridging the academic and not academic, and really telling the whole story with a focus on equity. And I thank you.